I compare cartilage oftentimes to pavement on a road. We're all born with a beautifully paved joint, and then you would expect that over time, just like a road breaks down, you get little cracks, you get potholes. At some point, the pavement is so beaten up that you have to redo the whole road. So there are 3 boxes that I put treatment options in. And one box is palliation. Palliation just means we make you feel better, but we're not structurally fixing anything. Surgeons come more into play with these other 2 boxes, and one box is reconstruction and one box is replacement. What's in the reconstruction box for me are joint preserving operations. I want to make what you have last longer. Those are things like cartilage transplants, osteotomies, meniscus transplants, but even meniscus repair, just preserving the meniscus rather than cutting it out. The replacement box, I do partial knee replacements, but that's an end-stage thing where you're almost bone on bone behind your kneecap or on the medial or on the lateral side, and there's nothing I can do to preserve that because there's nothing left to preserve. But I also have a lot of patients who are younger, who are in their 20s, 30s, 40s, so not the prime age where you feel good about replacement, and the damage in their knee is not advanced enough for replacement yet, but they have pain. And they've been around the palliation block a few times, meaning they've had a few rounds of injections maybe, they've had some bracing, PT. That's when they come in and say, is there anything else? And those I can, for example, repair with cartilage transplants. That's one thing I do a lot. We either take some cartilage from you and we grow more, or we take cartilage from donors. There's some synthetic implants that are pretty recent but exciting new technology. My toolbox of fixing knees without needing a knee replacement is definitely grown every year. For joint preservation, there's a window of opportunity where you have enough damage that makes it worthwhile to do something. But if you have too much damage, then at some point the joint preserving options don't work anymore. But the only way to figure out what's right for you is just really to carefully look at your imaging. I want you to also feel comfortable with the decision. I don't want to be the surgeon of, this is what you have, this is what you need, sign here. So we do have a discussion, but honestly, a lot of times at the end of the discussion, patients look to me and say, what would you do? And I promise, if I wouldn't do it in my kid, I wouldn't do it in you. If I wouldn't do it in my wife, I wouldn't do it in you.